Thank you very much, Mr. Chairman. It's my great honor to present my topic today. This is my disclosure. In Thailand, we have the 8 valve available in Thailand. So Vitaflow is one of our valve in the market. So let's go to the morphology of the Vitaflow. Vitaflow is made from the bovine pericardium for the leaflet, and the valve frame have the hybrid design. The upper part is the large cell, so you can see that is the low density, make the valve more compressible and less radial strength here. And the lower part is the closed cell, so it's very high radial strength, and it have the skirt. The skirt have made from the PET is the same thing as the Edward material. So the valve, it seems that it's not the very suture very tight for the skirt. It can be bulky when you put the valve have the vertical force. It will be bulky because it's a loose tissue around for the skirt, and they can have the blood coming through the hole here because the suture not close for the blood in the diastole to coming inside. So the skirt can bulky more when they put in the annulus, and it came with 4 size cover from the annulus diameter about 17 to 29. The delivery system have the unique character. It also have the motorized to make the operator we can do it with a single operator because you can control the catheter and control the wire and let the nurse to press the motorized to release the valve. So that is one thing of the benefit of the Vitaflow. And another thing is the catheter is moved freely, so it's not jump in much like the Evolut R from the original idea of the cell expandable. But the trade-off thing that is not the thing that I don't like is the size of the catheter will be bigger than other valves in the market. Other things that is the benefit from the Vitaflow is the diameter of the EOA of the valve is quite a little bit bigger than the Evolut from the market. Like the biggest one, the Vitaflow 30 have the EOA of about 28 millimeter. When compared with the Evolut 34, it have 24 millimeter. So let's see the case. This is the first case in Thailand. So it's not the AS case, it's the AR case with the history of the IE. So he is the ESRD patient of the 74 years old male who has the IE in 2022, and the right chori is the right cusp have the perforation, and after that, even though we initiate the hemodialysis 4 times a week, he still have the heart failure. So this is the picture of the chest film EKG and normal chori. So he refused the surgery all the time, and he have to admit for 6 months every month during the 6 weeks before we decided to do the TAVI for them. This is the STS score. He's the moderate risk, but still refused the surgery. The guideline says that TAVI for AI is a class 3. Why? Because AR lack of calcium for anchoring, and it have the large diameter of the aortic root and the annulus and also the aorta. So that's why it's very difficult to manipulate the valve. If we want to do it, maybe we have to increase the balloon size, so it may be cause the annular rupture, and it's very easy to cause the migration of the device, and sometimes it have the residual AR. This is the Vitaflow when you magnify. This is the skirt that you see. It have the gap around here, so the blood is coming and it can bulky. So I reviewed the paper and also talked to the proctor from China. They allow me to do the Vitaflow for this case because they says that the AR case with the annular dilatation or the root dilatation, we can have the 3-point anchor from the annulus, LVOT, and the ascending aorta. This is classified as a Type 1 Aurora classification. So they not recommend only the anchoring is at the LVOT level. In our case, And the anchoring, they have the degree of the anchoring. Like the annulus, they have to oversize about 10%, and it's not more than 20, not more than 30, because if it's more than 30, it squeezes the wall and it causes the pop-up. And the ascending aorta is less than 35. So the ratio between the alveoli and annulus is more than 0.95. All of these things will be suitable for the valve expansion, not too much for the radial strength to squeeze the valve pop up. So let's see this case. The diameter of the annulus in this case is about 26, and the alveoli is the same size, 25.6. So it's quite nice. And we have no choric occlusion problem, and the leg is quite big enough for Vitaflow. The choice of the valve is 30, and when we measurement in the systole and the diastole is the same. It's not different much. And when we calculate for annular Aurora criteria, it will be the annulus alveoli ratio is 1, oversize about 30 to 16%. And at the ascending aorta, it's oversized more, about 30%, but it have the less cell here. So it can stabilize because it can conform to the aortic root. This case is matching for the Aurora type 1. So we can do the anchoring with 3-point alveoli annulus and also ascending aorta. We choose the sentinel in this case because of the AR case. We worried about some debris can cause the stroke. So we can cause the aortic valve with the pigtail, and the gradients, it has some gradient because it's a high jet from the aortic regurgitation. So you can see the performance of the Vitaflow catheter. It can pass smoothly to the descending aorta, and without the calcium from the aortic arch, it can pass very well. But you can see its conformability to the arch is quite rigid, so it's not bending at the capsule and the valve inside the capsule. And the step of deployment, you have to start deployment at the same level as annulus plane, using the cast overlap like the Evolute technique. Just press the motorized, the capsule is going up, and you can adjust by using the Y pushing forward if you not like the position of the valve. And this is the things that happen when you press release from the motorized. It's quite stable. And with the nearly annular contact, we do the control pressing to make the valve more stable. And after that, I go to the LAO view and adjust the parallax of the valve and keep the tension on the catheter for a while to make the cell expandable more stronger when they stay in the body. And check the position of the valve and release the valve with the layover technique, as the Dr. Grada mentioned for the Evolute. So just slowly release centralized nose cone and just release the valve. As the technical, for me, is nearly same as Evolute technique. So it's quite stable in this case for the AR case. Okay, we can see because I have to slow down. Yeah. This is the final result of this case. So they have no parallel. The valve sit well in the annulus, and it have no gradient when we finish the valve without any conduction abnormality. So the conclusion of this case for the first AR Vitaflow in our country is possible because it's an Aurora type 1. We have three-part anchoring. The sentinel cannot catch up anything, no conduction abnormality. The patient recovery very well for the next and discharge for the next 2 days. No readmission from the heart failure again. The second case is also the case that's quite unique because he is the CVAS and AR do the first surgery Sauber on the 2012 And after, with the Hancocks, and have the valve degeneration in the 2018. And this is the third time intervention for the aortic valve because he have the trifecta failure. So the 3E show that the right cusp is failed. So when we talk about the valve in valve, we quite worried about the choric obstruction and PPM. So in this case, with the supineural design, we not worry much, but we quite worried about the choric obstruction. So we use the vivid classification, and this case for the vivid classification, the SOV is the valve is higher than the original orifice of the choric, but the SOV is very large. So we have no problem with the choric obstruction, but we quite worried that if we have the commissural pros in front of the left choric with the low choric height like this, it will be very difficult to do the PCI after TAVI. So the trifecta is out of the market in July 2023 because it have the early valve degeneration, because it have the external skirt and have the problem with the commissural post tearing and cause a very rapid degeneration. In this case, he used the trifecta size 23. The inner diameter is 21. So we choose the 24 valve. And at that time, I'm quite concerned about the commissural alignment in this case because I want to access the choric. So I think that I will use the commissural pose of the Vitaflow as the same as the commissural pose of the trifecta. The leg have no problem. He has a high STS score. He's a high-risk patient. So usually you can see that the capsule of the valve is not bending. It's not a good bending like this. When the proctor from China, they always recommend to use the snare if they think that you will face the problem or struggle with the crossing the arc or crossing the valve in the horizontal aorta, so that's why the snare can change the position of the tip of the catheter. Because it's a valve in valve, so they worry that we cannot cross the valve by directly cross the valve, so they recommend us to use the snare. And this is the position that I put in. I think it's a little bit high, but it's worked very well. But the true problem is when the valve is open, the commissural pole of the trifecta is gone because the density is the same as the stent frame. So I cannot do the commissural alignment in this case. And after release the valve for 80%, I try to lay over to make the valve more deeper. But with my less experience for the valve in valve, so the valve is pop up in the left side, in the right side. So this is the final result. Even though it have the pop up, it have the gap here. The valve is sit well because the radial strength is quite nice and skirt can seal the AR of this case. So when we do the CT 1 month after we put the Vitaflow, you can see that this is the trifecta leaflet. It helps us to seal the valve pop up here. And it's quite the function of the valve and the problem with the valve is have no problem because the gradient is good. They have no polar leak, but you can see that it have some halt happen in front of the right choric, and this is the halt in the right leaflet RCC class. So for my conclusion, the Vitaflow is when compared with another self-expandable, the Pro is the low-density stent frame, hybrid stent design. So the lower part have a very high radial strength, and the skirt design is very effective to correct the PVL problem. So the delivery system is quite big and less flexibility when the valve is coming inside the capsule, and no specific treatment for the commissural alignment. The deployment technique is same as Evolute, so you not have too much learning curve for this valve. Thank you very much for your attention.